Amit?
Yes, sir. Start.
Should I share the screen now?
Yes, sir.
So you tell me, when should I start the presentation?
So first you start with your introduction, and then yeah, you can start.
One sec. What is the video? Sorry about that. Hey. Amit, should I start? Okay. Good morning, everyone, and wish you all a very happy new year. So today I'm going to talk to you more about managing antiretroviral treatment failure, especially in a resource-limited settings. I'll also be covering, a little bit on antiretroviral resistance, and from that I'll take you on, what could be the possible regimens when someone has been failing, the first-line treatment. I'm sure everyone in the audience here knows about these two pivotal studies called HPT and 052, which was carried out to answer the question whether antiretroviral therapy can be used as a prevention tool, and also the study called START study, which clearly answered that there will be enormous individual benefit if we start treatment at a higher CD4. So these two pivotal studies very clearly showed that you need to start treatment for everybody. So that's what's shown in the 2016 WHO treatment guideline. Today, someone come to you. So if they're HIV positive, you can initiate treatment. Also, now we have new WHO guidelines. You can even start treatment once the patient is ready and you have been ruled out all the other co-infections and comorbidities. You can start treatment even on the same day. Again, coming to this, what you're going to start with before I talk about treatment failure. So these are the various regimens which has been recommended as part of these WHO guideline, which has been used for resource-limited settings. The preferred still being tenofovir 3-DCR-FTC with efavirenz, but many regions are already been changing towards those alternate regimens with an dolutegravir containing regimen. So this is because, not only just because of these efavirenz-related CNS toxicities, but also because of those baseline background NRTI resistance accumulating resource-limited setting. If you look into this graph, where x-axis is shown about the proportion of the people being covered with antiretroviral therapy over a period of time, and y-axis is prevalence of NRTI resistance mutations as shown in the y-axis in percentage. So when someone in the region have 10% coverage, now your NRTI baseline resistance is still less than 2%. When it is around 35 to 40%, it comes to almost like 4%. So and today the coverage is anything from 50 to 70% resource-limited setting. So we expect it come to anything from 10 to 12%. So this is something, what the epidemiological figures shows. So this is a true survey, which has been published by WHO in their resistance report, where you can see these y-axis by various countries and, x-axis by countries, and y-axis is the proportion of patients who have got NRTI resistance. There are many countries in African setting, they all have gone beyond 10% and above. And if you take our Asian countries, Philippines has gone to 8.5%, and Indonesia a little less than 5%, and Thailand is almost gone to 8%. What about in our region in India? There are some study shows it could be anything from 5 to 10%, but there are larger surveys currently undergoing with WHO in collaboration with our national program, which will tell us the results anytime soon. So currently we can assume it could be anything from 5 to 10%. That means we are almost like closing towards those the mark of 10%, which WHO guidelines very clearly recommend that you need to move an alternate regimen. So this is something, a new WHO guideline, which has been been launched a couple of months back, where in any regions where they have 10% or more baseline NRTI resistance, they should go into the non-NRTI containing regimen, that is with the dolutegravir for initiating treatment, or they should use baseline HIV drug-resistant testing, which is going to be very expensive, may not be possible in a resource-limited setting. Hence, it is strongly advised to move towards an alternate dolutegravir containing regimen. So this is something, a new guideline. Again, having said that, this is one of our published study, a few years back, which is a large randomized clinical trial, multi-site trial. We carried out, in collaboration with the US NIH and, many countries across the globe in Asia, India and Thailand, and many sub-Saharan African countries, and as well as Latin American countries participated in this trial to answer the question whether tenofovir can be superior or non-inferior to AZT containing regimen. In that particular trial, study called Pearl study, we also did a sub-analysis on resistance. So we studied all those patients who had failed, the antiretroviral therapy following this first-line regimen, which is around 270 randomly sampled patients. And in those, 218 had participants who had failed the ART group. There are two groups. One is the patients who have got failed group, which are called case group, and another one is a randomly sampled in that particular trial, which we call it as a sub-cohort of almost 270 participants. In the sub-cohort, again, this trial was done almost like 5 to 7 years back, where the baseline resistance in India, Thailand, as well as in African countries was around 4.2%, but it's almost like 5 to 6 years back. And in the case group, where patients who failed first line, the retrospective went back to screen the baseline resistance, which was almost around 7%, even 5, 6 years back. So that means it's very clear that baseline resistance predict a shorter time to virological failure, as shown in this slide. And also, we saw particularly because the study recruited patients across the globe with different subtypes, and patients who are with subtype C, they got a higher risk of failure, when they have any resistance mutations at baseline. So again, India, falls into this category. So we concluded this particular study and showed that pre-treatment genotyping should be considered whenever being feasible if you are going to use an NRTI containing regimen. So if you're going to move to dolutegravir, that would be the best choice, which I'm sure our region should move forward as soon as possible. So this is something the new WHO guidelines, where now alternate regimen, which has been recommended with dolutegravir, is going to become a preferred, and many regions in African settings have already moved into that, and India is in the process. So now moving to those, treatment failure management. So we all know that there is, there is only one definition for treatment failure today in the year 2018. So that is virological failure. So, but we have, other definitions like immunological failure and clinical failure, which we all had used in the past. But today, it's very clearly been shown that, the other failures follow, the virological failure. So, and also there are some modeling studies have shown that someone who fails virologically, they lead to immunological failure, anything from 6 months to 2 years after the virological failure time point, and to clinical failure, again, another from 2 to, even up to 2 years or even up to 3 years. So we are not going to do virological monitoring. You're going to end up in seeing patients much later. By the time patients can become sick, and also they can accumulate resistance mutations, which there are possibilities which they can transmit this resistant virus to their partners, and as well as they can also accumulate mutation, which can end up in jeopardizing future antiretroviral drug regimens. So today in the WHO guidelines, it's been strongly recommended to do viral load monitoring 6 months after initiating treatment. And again, the definition is that it should have a virological suppression. Either it could be less than 400 copies or 150 copies or less than 40 copies, whatever assay you have been using. Earlier we used a cutoff of 1,000, but now it's been come down to 400 because of these, usage of this cutoff in, many settings. So it's again been very strongly recommended, to use virological failure monitoring. So again, this viral load is being recommended to repeat after 6 months. And if it is suppressed, and you can repeat annually, to see these virological, success in those patients who are on antiretroviral treatment. In case if they have been failing, so what is the sequencing therapy today in the year 2018? So this is something what we are initiating patients with 2 NRTIs, with tenofovir 3 days in FTC, with either with an NRTI or with an integrates with dolutegravir. When they fail therapy, so what are those various mutations you'll see? Again, I'm not going to talk about much about the failure of dolutegravir, because which has been very recently been launched in our settings, but I'll talk more about, these NRTI containing therapy. Someone who fails, if they are initiated with tenofovir, so one of those first mutations they developed is for mutations to 3DC or FTC, which again, if you don't identify and switch, and it can end up in developing NRTI mutations. And again, if you don't do the viral load monitoring and switch, and it can accumulate K65R, which is a signature mutation for tenofovir. Again, but if you have been started with AZT containing therapy, which again, in our region, we had used a lot in the past, but still in some regions, we have been continuing those old patients if they fail. Again, one of the first mutations to develop is the mutation for 3DC, and which is followed by, TAMS, which is thymidine-associated mutation for AZT or for D40. There are some regions and have published that, especially in subtype C, if they develop a TAMS, they also can, accumulate A65R. There are possibilities which can jeopardize the efficacy of, tenofovir. So if you have been initiating on tenofovir containing therapy, if they fail, the ideal second line should be on AZT. If you have been used on AZT, if they fail, then they should be used the tenofovir containing regimen, for second line. What about these NRTI when they fail? When they accumulate mutations, what could be those third products? Today, it has been very strongly recommended in almost all the guidelines, both in the resource limited as well as in the developed world guidelines, is the usage of protease inhibitors. So it should be the strong second line backbone along with the two NRTIs. There are three different protease inhibitors been recommended, which is either boosted arachnavir once daily, or boosted lopinavir, which is twice daily, and also boosted darunavir, that is with 800 milligram darunavir with 100 milligram ritonavir as once daily. So these all the three regimens are being recommended as part of those guidelines. But there are a lot of pros and cons. Like again, our greatest experience in our regions is either with arachnavir or with lopinavir because of the wider availability. But again, in this particular table, where you can see either the pros and cons. So if you look at the pediatric regimens, is only the lopinavir is currently been available, but we don't have with arachnavir or darunavir. And if you look into those pill burden, which is very, very important, because today we are talking about the fixed dose combinations. With boosted arachnavir, we have got a single pill available, which is arachnavir boosted with ritonavir. But in lopinavir, they need to take 4 pills, 2 in the morning, 2 in the evening, which again, it's a huge pill burden. And with the boosted darunavir, in the past, we had to take 4. But now, thanks to the effort by the Indian generic manufacturers, we are able to reduce it to 2 pill a day, which is again, making it much easier for the patients if they're taking darunavir once daily. But again, arachnavir is once daily, lopinavir is twice daily, and darunavir today in 2018, it is once daily. And if you look into the safety in pregnancy, all those 3 protease inhibitors have been, recommended, and it's been safe in pregnant. And if you look into those gastrointestinal disturbance, when arachnavir is not frequent and lopinavir is common, and darunavir is also not frequent. Availability of co-formulations along with ritonavir, which is very important. With arachnavir is available, with the lopinavir it is available, and with darunavir, when the guideline was launched in 2016, it was not available. But today, thanks to those Indian generic manufacturers, now it's been available, for our patients. Coming to the usage of these protease inhibitors with TB patients, which is again very important. So one of those important reasons for patients who have been failing clinically, where again, you can't use rifampicin with arachnavir, you have to use rifabutin. You can use with lopinavir, but you have to change the dosage of lopinavir. And again, with the darunavir, rifampicin is contraindicated, where you have to use rifabutin. So other adverse events like hyperbulimia, which you all know that, which is a very common problem with arachnavir, not seen in the lopinavir and darunavir. And very importantly, the dyslipidemia, which is again very common with the lopinavir, which many of our patients who are put on lopinavir, they develop abnormal lipid profile. But with arachnavir, which is very modest, and is darunavir again is is seen, but not that high as lopinavir, which again make it much more better. Potential for future cost reduction, which is again very important for resource limited setting, either in the private program or in the public program. So arachnavir today has been very cheaper, and lopinavir, it's been moderately expensive. And darunavir used to be very expensive, but now again, thanks to the development of these co-formulations, is becoming cheaper, but again, still expensive. But there are possibilities where there is this cost can come down. Very importantly, whether these drugs are available in India from the generic market with Arachnavir, yes. With Lopinavir, yes. With Darunavir, today it's been available. The booster Darunavir formulation is been available. So with all these, where you can choose depending upon what is good for the patients and based on their comorbidities and also based on the availability and as well as based on those economic status and as well as availability in the program and also on the based on the adverse events. So today, this is again, I'd like to tell you that we do have a Darunavir with Ritonavir co-formulation available, but this particular tablet is available as a 400 milligram and with 50 milligram Ritonavir. So you need to give 2 tablets once daily. So I want to show data between an Arachnavir and Darunavir, for second line about based on their adverse effects. So again, why I want to show this particular graph in this from this clinical trial, which is called ACTG 5257, which was funded by NIH and published 4 years back, is because in our region we use a lot on Arachnavir for second line, and Darunavir once daily is now launched in India. So if you look into those adverse events, there are a lot of bar charts. You can see this, but you can look into those second chart, which is a very much lighter green, where what it shows is this x-axis is various different regimens, and y-axis is proportion of patients who have been developing adverse events and discontinuing from this particular clinical trial. If you look in this Arachnavir, there is a second bar chart where the rate of discontinuation is much higher as compared to Darunavir, which is much lower. That means Arachnavir can be more toxic to our patients as compared to Darunavir. This again very clearly shows that Darunavir can be a much better second line, much better tolerable second line on a long run, to our patients. But also clinical trials have shown, the Darunavir is been non-inferior to almost all the PIs, and also studies have shown even in superiority because participants who have been enrolled in other protease inhibitor containing regimens have dropped out because of toxicity, thereby making Darunavir can be a superior regimen as part of those second line, especially with once daily with Darunavir 800 with 100 milligram Ritonavir. But again, as I said earlier, you'll not be able to give rifampicin along with this. It's been contraindicated. So when you administer rifampicin 600 milligram with Darunavir, which decreases Darunavir AUC by 57% and 26%, and hence it's not been recommended at these dosages. So if you do this, the Darunavir level can even go to 400 milligram, where we do not know the efficacy of low-dose Darunavir in terms of suppressing the viral load. But there are certain studies been ongoing, like Darulite, where we'll have more results on this in the next few months. At this time, rifampicin is not been recommended. You need to give, rifabutin. Hence, sequencing therapy in 2018 is someone who started with tenofovir 3-DCF-TC with favrins or dolutegravir. You switch them to 2 NRTIs, from tenofovir to AZT, and from NRTI to one of those PIs. Again, I have said about the pros and cons of Arachnavir versus Lopinavir versus Darunavir, in those, earlier slides. But again, when you've been changing from tenofovir to AZT, which you all know that Pearl study and several other studies have shown AZT is more toxic to our HIV-infected people, both on a short term as well as on a long term. Short term, it can produce severe anemia, nausea, vomiting, and on a long run, it can produce severe metabolic syndrome as well as severe lipodystrophy. And also, there are reports coming up that the development of diabetes in, especially in Indian HIV-infected people. Thereby, can this be a safe option along with one of those potent, again, clinical trials have been carried out. Do we need to have an alternate to this AZT? Again, 3 such trials been carried out. A study called second line trial, another trial called Select study, which was funded by NIH, and a third study called Earnest, which was carried out in, in sub-Saharan Africa. What these trials, 3 trials did was, is compared the standard 2 NRTIs with a boosted Lopinavir along with a new regimen with the integrase inhibitor of raltegravir. It's a very large clinical trial, which was, carried out in many countries. And Chennai, our site, participated in both the second line study as well as the Select study, and as well the Earnest study, was carried out in Africa. So this is a snapshot analysis of those second line study of 48 weeks analysis, where again, x-axis is showing the duration of follow-up, and y-axis is proportion of the patients who got suppressed viral load. Where this blue color line graph is patients who are on lopinavir, the raltegravir, and the red one is on patients with 2 NRTIs with the lopinavir, where it shows that raltegravir with the lopinavir, is being non-inferior, in HIV-infected people who are put on, second-line therapy when they have first-line NRTI containing failure. Again, similar observations were also seen in the Earnest study and as well as in the SELECT study, where again, raltegravir containing regimen in the instead of AZT is being, non-inferior. And as a result of these 3 studies, it also been recommended as part of the WHO guideline. If you cannot use AZT or if you do not want to use AZT, you can use an alternate to that. That is an integrase inhibitor. Today is raltegravir, which is twice daily with one of those, potent protease inhibitor, which we, described, a little earlier. So you may also ask a question: can we recycle this tenofovir, instead of this AZT? Because if you're doing viral load monitoring, where if they failed in an NRTI, if you're doing a genotyping, and if you see that there are no resistance mutations, you can definitely recycle instead of AZT. But if you're not going to do resistance testing after the first-line failure, so what you'll see is, this is a study, what we all participated is a large global study, which was carried out in Europe, in Latin America, North America, Sub-Saharan Africa, and in Asia, including here in India and Chennai. So what we particularly did in the study is, patients who have been initiating the tenofovir-containing therapy, if they have failed virologically, their resistant testing was being done, where again, this is what been found in this particular trial is, study is the prevalence of tenofovir resistance was the highest, especially in Sub-Saharan Africa, almost like 57%. So that means if you're blindly changing from tenofovir again to tenofovir, where 50% of the patients, tenofovir will not work, will end up in a PI monotherapy. So there are a lot of other cofactors also been found as part of these, colleagues. And what's been seen in Asia is almost around, you can see this particular graph where this is x-axis is different regions and y-axis is number of patients, proportion of patients with resistance mutations to NRTI. So again, as well as to, tenofovir, where if you see this, the third bar in, each group, which is for tenofovir, where in the Asia, which is in this first group, where it shows almost 39% tenofovir resistant K65R as compared to almost like 50 to 60% in Sub-Saharan Africa. So that means in India, if you're not doing resistant testing, if you're changing from tenofovir to tenofovir, again, almost like around 40% of them, it may not work, it can end up in a, PI monotherapy. Hence, if you have been switching, it's better to do genotyping and based on sequencing. Otherwise, you have to switch to a newer regimen, as said in the public health program. Now, having said this, so now there is a new particular study had been, for this particular reason it's been carried out, whether can we use dolutegravir for second line along with the 2 NRTIs. So this is a study called Dawning study. Now it's been presented and published, where what these investigators did was they recruited patients who are failing NRTI containing therapy, which were never experienced to dolutegravir. They randomized into 2 different groups. One group receives 2 NRTIs and dolutegravir. Another group received 2 NRTIs and boosted lopinavir. But in this trial, they did the baseline resistant testing, and if they had any NRTIs resistance mutation, then they use alternate NRTIs. Hence, this particular trial outcome cannot be generalized in a resource-limited setting. But very interestingly, this trial also showed 2 NRTIs with dolutegravir, which is non-inferior to 2 NRTIs with a boosted PI, as shown in this particular bar chart, where you can see this blue color one is a 82% virological suppression with dolutegravir, as compared to 69% virological success with a boosted PI and the 2 NRTIs. Very clearly shows that dolutegravir has been superior. And also, when they did this particular protocol-specific analysis with the treatment failure being censored, where again, they very clearly shows that 86% versus 72%, very clearly shows that dolutegravir containing regimen is much superior as compared to PI containing therapy. Can we use similar things in a resource limited setting? Currently, there is no resource limited setting guidelines been recommending this because we don't have a randomized clinical trial data. To answer this critical question, currently we have been doing a very large study. It's in the initial process, very initially been started recruiting, and is a very large study. It's going to happen in India, in Thailand, in Malaysia, and several African countries as well as Latin American country. This will be a 3-arm study. This is a study called DEF study, which will compare on patients who are failing NRTI containing therapy. Will be randomized to either 2 NRTIs with once daily boosted darunavir, or boosted darunavir once daily with dolutegravir, or whether they'll be switched from tenofovir containing therapy, which are already on an NRTI, to again tenofovir with 3-DCR FTC with dolutegravir. So again, a very ambitious study. This is going to be carried out on, I think, on 900 odd patients, 300 in each arm, where again, it will take another, a couple of years to know about the real outcome of this study. So we need to wait for the results, how we can use this very effectively in a resource limited setting if you have been, switching to your dolutegravir along with tenofovir. But if you wanted to use it in your, in your patients on a case-by-case basis, you need to do a resistant testing to NRTIs after the first line failure. And based on that, might be you can use this because Downing study very clearly shows that tenofovir with 3-DCR FTC with dolutegravir is non-inferior, even superior as compared to 2 NRTIs and boosted darunavir. But if you're not using genotyping, don't straight away switch it, because you may even lose dolutegravir because dolutegravir monotherapy may not be efficacious, as shown in several studies in the past. So moving to the third line, so if patients have been failing a second line, so this is one of our very earliest study, almost like 5-6 years back, from our cohort here in Chennai at Virologic Care, on patients who are receiving second line therapy with boosted arachnavir or lopinavir, on a very large number who had, when they had virological failure, we did a resistance mutations. Almost around 111 patients had access to mutations almost 5 years back, which is used for one of those WHO guidelines discussions. So what we saw particular in this analysis is where you can see these almost 94 patients had used boosted arachnavir and around 17 patients with boosted lopinavir. When patients are failing, virologically failing with boosted arachnavir, 63% of the patient had no major PI mutation for arachnavir. So that means there are possibilities if you're doing resistant testing, these drugs can be recycled. And again, with lopinavir, almost 75%. And similar observations are also been seen recently in Africa, as well as in Thailand, as well as in Latin America. Also, another major study, which will be very recently being conducted and will be presented in March at the retrovirus conference. So this very clearly shows that if you have been changing from second line with a boosted PI, if you are virologically failing, it's worth to do a resistant testing before we switch them. If we don't do the resistant testing, you might be switching unnecessarily, and you may even lose those drugs which are still being efficacious. So someone who is already on darunavir containing first line therapy, second line therapy with once daily, 800 milligram with 100 milligram ritonavir, if they fail, they can develop any one of those mutations. And also studies have shown, even if they develop any one of those mutations, if you change from darunavir once daily to twice daily with 600 darunavir with 100 ritonavir with twice daily, still will be active. So today in a public health setting, if you have a resistant testing, better to use a resistant testing. If you don't have it, you have to switch from once daily with any one of those PIs to darunavir twice daily, and you have to change them to an integrase inhibitor if you're not used in the past. But you have used integrase inhibitors in the past, and if they have failed either first line or as a second line, then dolutegravir dosage should be doubled. Again, we need more data on that. There are studies being undergoing. And also, if you got genotyping available, then you can recycle NRTIs. And if there are availability of second generation NRTI like etravirine based on the genotyping, where can you still use them? So, but if you don't have genotyping, we may not know the efficacy of NRTIs, and as well as the NNRTIs as part of those third line. There will be again more presentations and upcoming retrovirus conference from our group, from one of our ongoing clinical trial called ACTG 5288, where it will inform in a public health setting, where even if you don't have a genotyping, what could be those best third-line, regimen. But again, these regimens will work very well, if you sequence them appropriately using the proper monitoring with viral load. But if you don't do viral load monitoring, which you all know that, there are patients who can accumulate mutations, especially when you have been using PIs for second line. If you're not doing genotype, if you're not doing viral load monitoring, doing only CD4 or clinical monitoring, there are possibilities that PI mutations can accumulate, and definitely they can jeopardize the third-line regimens, especially darunavir containing regimens. So this is a study called Power Trial, which has been carried out many years back to understand the efficacy of darunavir for third-line or for treatment failure. But again, there's a sub-analysis been carried out where, as shown in this particular graph, where you can see on the left side panel in your screen, where x-axis is a number of primary PA mutations, and y-axis is proportion of the patient who got suppressed viral load within week 24. So what's been shown is if they have 0 primary PI mutations before you switch them to the darunavir, the chance of virological suppression is more than 60%. But if they have 1 mutation, it comes to 50%, and if they have 3 or more, the virological success becomes less than 20%. So that means if you're not doing viral load monitoring during second line on PIs, if they fail and if they accumulate, the efficacy of darunavir can further go down. Hence, it's very important to do viral load monitoring, even when the patients are on second line. And also, there are studies have shown the efficacy of second generation NRTI like etravirine can also come down, if you don't do viral load monitoring, as shown by our group and others, in the past. So today, this is a WHO guidelines, which very clearly recommends for second line, which is a major core of my talk today, where you use 2 NRTIs with boosted arachnavir, or boosted lopinavir, or boosted darunavir. But if you can't use NRTIs, you can also use raltegravir twice daily. Can we use dolutegravir instead of raltegravir? Currently, studies have been ongoing. We need to wait for the results. Hopefully, it can show some light on that. Can we recycle the same NRTI, that is tenofovir, in second line? Again, studies have shown there are possibility of tenofovir mutation after the first line failure. And it's better to do a genotyping if you want to recycle, otherwise switch to the alternate in a second lines. Also, the guidelines very clearly recommend what could be the possible third lines when they fail the second line PIs, where darunavir twice daily, and if they have not been used, the integrase, with the dolutegravir, or they have been used integrase inhibitors for first or second line, then dolutegravir has to be, twice daily. And also, based on the genotyping, you can recycle other possible drugs which have been available. So again, before I conclude my talk, we talked about in the past about various types of monitoring, and as well as today we have been talking about the need for viral load monitoring. And also today in 2018, I'm also been suggesting that use resistant testing, wherever available. So from our personal experience, these are some of those suggested indications for using resistant testing in resource-limited settings, for taking care of patients. For baseline testing, so suppose someone comes to you, if the partner is on a failing regimen, if you're initiating antiretroviral drug to the partners, and if the partner is on NRTI containing therapy, if you want to use an NRTI efavirenz containing therapy, better to do a baseline testing, because there are possibilities this particular individual could have acquired even a resistant virus from their partner. But if you're using other dolutegravir containing regimen, that's perfectly fine. And also, if the patients are already exposed to any other suboptimal exposure, either monotherapy or dual therapy, or any type of regimen for mother-to-child transmission intervention, better to do a genotyping before initiating treatment, or move to the alternate dolutegravir containing therapy. After the immunological failure, so current WHO guidelines and resource-limited guidelines doesn't recommend, but it has also been advisable. If you do this, you'll be able to know that how many times they have accumulated they are on AZT containing therapy, or if you want to recycle tenofovir from first line, you'll also know that whether they have harbored K65 mutations. And also, it's also worth to know about the number of NRTI mutations, because now in future we have new NRTI drugs have been available, so that can work. If they have 1 or 2 mutations, so it's worth to know about that. Soon after the first line failure. And definitely after the second line failure, it is needed, because it will help us to preserve the PIs. If they don't have mutations, still you can recycle the second line PIs. If they have developed, then it's also worth to know that how to sequence the third line. So these are certain suggested indications in a resource limited setting where you can use resistant testing to switch patients. Also, don't preserve certain drugs like darunavir. There are a lot of talks going on that can you preserve darunavir only for third line. So, my suggestion is don't do that. It's such a potent drug, where you can upfront use it for second line as once daily. So even if they develop mutations, don't worry about that. There are a lot of other newer PIs coming up. So this is a new PI called GS-PI 1, which is the preclinical state, but there will be more results will be presented soon at the virus conference in March, where it is a potential for unboosted once daily. Again, it will be better for resource limited setting, and also shown that it has got a higher activity against the artesunavir and darunavir resistant virus. So hence, use the best drug upfront and give the benefit to our patients. With this, I'm going to stop my talk and happy to take questions. Again, thank you for your patient listening on this wonderful Sunday. Thank you. Right. So there are some questions have come now. I'm going to read the questions. I'm going to answer to you. And again, thanks everyone for asking. I think it has come from Pan-India, from throughout. So the first question is from Surat, from Dr. Jayesh. The question is, effect of rifampicin-based antituberculous therapy on nevirapine plasma concentration in adult HIV-associated tuberculosis. So today we don't recommend rifampicin, with nevirapine. It's long been shown, not only the interactions, but also risk of severe hepatotoxicity between nevirapine and rifampicin combination. Hence, it has not been recommended. It's long been, moved out of those on all those guidelines. Hence, don't use it. If you're using an NRTI, use efavirenz. The next question is from Telangana, from Dr. Farouk. The question being, what are the adherence resistance relationship to combination antiretroviral therapy? So again, it's very important, where to talk about adherence. Again, in my talk, I didn't cover much on that. One of those important reasons for treatment failure is not adhering to these regimens, where if the patient don't take it, the virus goes up, and if there are, irregular and the various blips which can happen over a period of time can end up in resistance mutations. Hence, it's very important to improve adherence. So counseling on this is very, very important. And also various studies clearly shows that more than 80% adherence is very, very important. And also, again, if you have been using weak genetic barrier drugs like efavirenz, where you need a full adherence, otherwise, it can end up in resistance. The next question from Delhi, from Dr. Verma. Can you elaborate the influencing medication adherence among women with AIDS? Again, I need to go through the question. Elaborate the influencing medication adherence. Okay, again, medication adherence in women. So again, I think it's whether men or women, I think adherence is very, very important. Again, studies have shown where women have higher adherence as compared to men because they take this drug well. But also in our settings, I think this should be closely studied, whether women, for various their own personal reasons, are they taking these drugs regularly or not. Whatever gender we are talking about, I think adherence is very important. Adherence counseling is very important for better virological success. Next question from Haura, from Dr. Pranab Derb. The question being, what are the efficacy of a group of medication adherence intervention among HIV positive women? Again, the same thing on adherence, again, is very important. I'm not going to the details of this. And next question from Margot, from Dr. George. The question being, what are the guidelines for the management of HIV and AIDS in adults and adolescents? So again, that's what I talked about. The one used in research-limited setting is the WHO guidelines, and India follows that. And in India, in the national program, we have their NACO guideline, which is again adapted from the WHO guideline, but little modified for Indian setting based on the availability and as well as the economy. And it's been a little modified. But in many settings across the globe, in resource-limited setting, the guideline used is by the WHO guidelines, which has been developed with the best available data across resource-limited settings. Next question from Dr. Deepak from Mumbai. Is using HIV on RNA threshold less than 200 copies better than less than 50 copies? Again, no one knows. The whole idea is going towards, the virological suppression. I think definitely less than 50 copies better than less than 200 copies. But if you don't have less than 50 copies, I say better to use a less than 200. I think less than 200 is definitely better than less than 1,000, which we used a lot earlier. But again, in your assays, if the patients are having a viral load of anything between 50 to 200, again, these are the patients need a lot of adherence counseling. That means they have been missing pills where, good adherence counseling and implementing, very close DOT-like, procedures will help to have a better virological success, because these patients can develop a virological failure if you don't intervene. I think you can use that type of indicators, on these patients if they have been having a low-level viremia. Next question from Patna from Dr. Tiwari. So what are the impact of low-level viremia on clinical and virological outcome? That's again, I just answered. Again, when patients have low-level viremia, so that means definitely the patients are being, I won't use the word failing because that has got a definition. Need to have a 2 viral load within 3 months, 6 weeks to 3 months apart, with a good adherence counseling. Where they have been viremic, then is a definition for virological failure. But if they have just one-time low-level viremia, less than 200 copies, more than 50 copies, I think these are the individuals who need appropriate adherence counseling. Otherwise, they can end up in losing the drug, and also, of course, they can also transmit virus to their partners. These are the various impact of low-level viremia. The next question from Pune from Dr. Naran. Is it mandatory to do drug resistance testing before initiating darunavir? Again, when you're going to use darunavir is important. If you're going to use it for first line, which again, we are not going to use it, but we will use it for second line because we have once daily PI. If they're not exposed to a PI, you don't need to do that. But again, definitely as part of the third line, because we'll be using one of those PIs for second line. So you need to know about how many PI mutations are been there. So before we change them to, darunavir for, third line. So too many PI mutations can also reduce the susceptibility to, darunavir for third line. And it will also help you to, bring the best sequence for with other possible regimens, as part of those third lines, so that they will be virologically successful when you use darunavir with those pattern of mutations. Next question from Kerala from Dr. Prasad. Is virological failure following persistent low-level viremia in a cohort of HIV positive patients? Yes, again, the question on low-level viremia, yes, quite possible. If you're not doing adherence intervention, patients are still missing pills. They can have blips, which can end up in virological failure. Next question from Chennai, my own city, from Dr. Mahan. What would be the suggested for patients with tenofovir-based regimen with a raised renal function test and uncontrolled diabetes? Should the regimen be changed? Again, is depending upon what regimen they are on. It's on either for first line or for second line. When they're on first line, yes, definitely, immediately it can be substituted with the bacavir, to prevent further renal function. But again, before doing a bacavir, better do a HLA testing, to avoid the risk of hypersensitive reactions. But when you're on, second line, when it's tenofovir with the renal functions, then again, substituting with the bacavir, you have to be careful, because abacavir also harbor similar mutations to 3DCN as well as with the thymidine analogs. And someone, if they're already exposed to those regimens in the first line and they fail, they have house mutation, abacavir susceptibility can be very minimal. Hence, abacavir cannot be a good drug, for second line, at this time. Then you need to go through those alternate to those NRTIs, either to go to the raltegravir And again, with dolutegravir, we don't have much data, especially when someone who has got a renal functioning impaired. The ideal choice could be raltegravir, 400 milligram twice daily, along with the PIs for second line. So next question from Hyderabad from Dr. Ishwar. Which one you suggest for first line failure, either dolutegravir or darunavir? Again, since we use dolutegravir for first line, which is going to be preferred soon, so I think darunavir will, with 2 NRTIs with darunavir once daily, should be the option for second line. But again, if you use NRTI for first line, then can you use dolutegravir for second line instead of darunavir? The answer can be yes, but you need to do a genotyping to know whether the NRTI mutations, if you're going to recycle tenofovir. But on the other hand, if you're going to use the AZT, then based on the Downing study, yes, that can be a good choice. But we are looking for more data from resource-limited setting, to push it into these resource-limited setting guidelines. The next question has come from Kolhapur from Dr. Santesh. The question is on the DEP study. So what is the darunavir dosage used? Again, I didn't show the dosage in my slide. I think it's that darunavir is 800 milligram once daily with ritonavir 100 milligrams. The next question from Dr. Jyoti from Chennai. So what are those pre-existing minority drug-resistant variants, adherence, and risk of antiviral treatment failure? Again, I showed, now we do have some data from resource-limited setting, especially the presence of pre-existing mutations to the risk of virological failure. I showed a data from the PEARL study, which is published, which shows that if they have persistence mutation, chance of failure is much higher. And also there are a lot of other groups currently been studying that. Hence, pre-resistance mutation definitely play a huge role in causing treatment failure. And of course, adherence, counseling is very important. Next question from Calcutta, from Dr. Bijoy Chatterjee. So what's the efficacy of Infotide in patients infected with a drug-resistant virus? Here, the question is on T20, which is a fusion inhibitor. Again, these drugs are not available in India, so we don't have much experience or anything on that. But these drugs are being used in certain resource-rich settings where when they have no other drugs available, where it's been used, but it has to be given as an injectable. Also, certain infusion pumps are available. It's been efficacious when no other drugs are available. But on the other hand, the complexity being it has to be given as an injection. And there are a lot of injection abscess and a lot of other complications related to that being noticed. Not sure that it can be a good drug for resource-limited setting. Again, it's not been available right now, so we will not be able to talk about our own experience in our setting. Next question, again from Dr. JD from Chennai. So to replace efavirenz in a failing regimen, which drug to consider? Darunavir or dolutegravir or raltegravir, or do a genotyping resistant testing to proceed? In ideal scenario, do a genotyping, and based on that, you sequence the best drug. But if you don't have a genotyping in a public health setting, then change from NRTI to a protease inhibitor, either to an arasenavir or to a lopinavir, or today darunavir once daily available, either to a darunavir. But on the other hand, I said earlier, Downing study shows dolutegravir with 2 NRTIs can be non-inferior and can be even superior. But on the other hand, we need to do resistant testing to NRTIs. Definitely not raltegravir. There are trials had been done for second line after the first line failure using raltegravir with 2 NRTIs. These studies have shown which has been been failed. So raltegravir should not be used along with 2 NRTIs for second line after a first line failure. So raltegravir can be best used for first line if you can't use dolutegravir, or it can be used for second line along with a boosted PI. Next question from Mumbai from Dr. Ajay. What is the efficacy and safety of darunavir ritonavir at week 48 in treatment experienced patient with HIV-1 infection, POWER 1 and 2 trial, which again, I've shown this in my slide, hence I'm not going to the detail. Again, the sub-analysis of this POWER trial showed if the patient have more PI mutations, the efficacy of darunavir for third line, it can come down. Hence, it's very important to do viral load and make sure that patients have been suppressed while on PIs, and if they are virologically failed before they accumulate PI mutation, better to switch them, to the third line. Okay, next question from Hyderabad from Dr. Ishwar, which again shows what proportion of the patients on HIV-2 can be treated with darunavir. Of course, darunavir can be a good drug for HIV-2, either for first line, or if you use other drugs like raltegravir or dolutegravir for first line, you can use darunavir for second in HIV-2. The efficacy is excellent. Next, again, a very important question from Chennai, from Dr. Pungalali. Again, the question being, can we use once daily darunavir, in pregnancy? Very important question. I do not know the answer, but I can say that based on the available evidence, darunavir is safe in pregnancy. But again, it has been not studied in pregnancy on the virological suppression. So we assume, they are being non-inferior to arasenavir or lopinavir. Hence, it can be recommended as per the current guidelines, but I have not seen any, clinical trial data to show that darunavir once daily, in pregnancy. It's based on the available data in terms of virological suppression, as well as the safety data in pregnancy. Definitely can be recommended in pregnancy as once daily. But again, it's an excellent question. We need more operational study evidence from our cohorts once darunavir are widely used and in pregnant women. The next question from Goha, from Dr. Charles. What are the subgroup analyses of Maraviroc in previously treated R5 HIV-1 infection? So it's a question on Maraviroc. I didn't talk anything on that because it's been not part of any of those resource limited guidelines. But of course, we use this in India because it's been available. So currently it has been preserved more as a, for salvage regimen, most for third line. Again, this is a drug. How it works is it uses CXCR5 R5 receptor, for blocking that. So if you're going to use this, you need to know that whether the particular patient is harboring this, CCR5, receptor. If they don't have that, this drug is not going to be useful. Hence, before doing this, you need to do a CCR5 receptor testing, which is currently available in India. And based on that, this drug can be used as part of those third line or for salvage regimen, if the other drugs are not being available. The next question from Aurangabad, from Dr. Shilpa. The question being, where you will put the darunavir 1200 and darunavir 800? So again, good question. Darunavir 800 definitely for second line, or even can be used for first line, which again we're not recommending. And darunavir 1200, that is 600 milligram twice daily, for third line. Next question from Delhi, from Dr. Prakash. Interruption of infertility in HIV-infected patient, virological suppression on again, we talked this about T20, so we don't have much experience in resource-limited setting. Again, very complex drug, which has to be given as an injectable, is used as a salvage therapy in research-rich settings. Next question from Dr. Jadhav from Solapur. Can darunavir ritonavir fixed dose combination be used in TB patients? And of course, can be used in TB patients, but it's been contraindicated with rifampicin. You may have to use rifabutin. There are studies underway to see the interactions between rifampicin and darunavir. The current evidence shows it can reduce the AUC of darunavir by 57%. So thereby, we do not know those low dose darunavir efficacy in terms of virological suppression. But there is a study currently undergoing called Darulite study, which may show more light on this in the next few months. At this time, you need to use rifabutin along with darunavir, ritonavir, once daily, for second line. Another question from Dr. Manohar from Nanted shows dual therapy with the lopinavir, ritonavir plus lamivudine versus triple therapy with the lopinavir, ritonavir, along with the 2 NRTIs. And again, the usage of certain dual therapy, especially in patients who have got suppressed viral load, is getting popular, especially in research settings, and also became prominent as part of certain guidelines to avoid toxicities. At this time, we are not recommending this type of options in a research-limited settings unless you closely monitor these patients' viral load, because the efficacy of such regimens may not be good, and we need very close viral load monitoring, to know that whether they have sustained virological suppression. But we will have more and more data on such dual drug strategies, especially as a maintenance therapy when someone is suppressed along with a triple therapy to avoid toxicities, and as well as for simplicity. There are a lot of such strategies are under development. Some strategies are now, into some of those risk setting guidelines as part of those maintenance, but we need more evidence in a resource limited settings, whether, that can be provided as part of a standard of care. Next question from Bihar, from Dr. Neeraj Jha. What are the effects of central nervous system, antiretroviral penetration, and cognitive function in the alert cohort? Okay. Again, a question on CNS. Again, you all know that various HIV-infected people now, when they're on therapy on a long run, they develop neurocognitive impairment. It's not, I'm not talking about neuro AIDS or any of those opportunistic infections, but it's more of a neurocognitive impairment because of the poor penetration of some of those commonly used antiretroviral drugs. As a result, there is a CNS escape of HIV virus, which can develop and reservoirs the CNS system, which can also lead to some of those neurocognitive impairment. And now we have studies being done by the University of California, San Diego group, which have recommended that certain regimens are superior as compared to certain regimen. Again, we need more and more such studies as well as trials before we recommend anything as part of those guidelines. Currently, as part of the patient care, we use in our regions, someone who's virologically suppressed in the plasma, if they have neurocognitive impairment with clinically and been and with other possible investigations that have been available here, if you diagnose as neurocognitive, we prefer to change some of those drugs based on those CNS scores to those drugs which penetrate better into those different reservoirs. Probably this will be the last question because we are at the end of the hour. Again, this is a question from Madurai from Dr. Pashugod. So this is a question on, can Darunavir 800 milligram can be given as a monotherapy in first line? Definitely no. We don't have any data on this to give Darunavir 800 milligram as a monotherapy. That too, especially for first line when someone is being extremely viremic. This time definitely not being recommended at this stage. Again, we had a lot of questions, almost like 30-odd questions, and I'll be very happy to answer more and more such questions through email, and you may access to my answer responses through email in future. So since just for one-up time, I'm going to say bye to you, and thank you again for this opportunity, and thanks for this listening, and and again, best wishes, and I'm sure this presentation would have given some light on your patient care, especially managing patients after first line and second line failures. Again, thanks again. Bye-bye. Have a good day. Bye-bye.